Hi, I'm Dr. Michael Miyazaki, and today we're going to be talking about why you'd want to do endodontics if you're a general dentist. Maybe the follow up to this program is going to be why you would want to do restorative dentistry if you're an endodontist. We'll see. But what I really want to do is discuss why, if you're a general dentist not doing endodontics, why you might want to incorporate endodontics into your practice. Um, I know when we go back to when I was learning how to do endo almost 40 years ago, it was an arduous process and it was really hard and took lots of time. And by the time I was done doing a root canal, my fingers were sore. And when I got into private practice, if I had two root canals on my schedule, I knew that was going to be a tough day. And if I had three or four, then I knew I was going to go home and my fingers were going to be really, really sore. Well, fortunately, just like everything else in dentistry, over the last 40 years, doing a root canal has gotten much easier. I think one of the things that's gotten harder is that in dental schools, there's a lot less time allotted for the students to learn how to do root canals. So when I talk to many of the new graduates today and I ask them how many root canals did you have an opportunity to do while you're going through dental school, many times it's a very low number, maybe even zero. Some young students I've taught to have had a chance to diagnose and open up the tooth, but they never had a chance to do the actual root canal, even while they were in dental school. So our experiences differ. With the way that we learned 40 years ago is we would start off by finding the canals, and then we would have to file from maybe a '08 file to a 10, 15, 20, 25, 30, 35, 40, 45, 50, sometimes even up to a 60. And we'd have everything cleaned up and be able to get our gutta percha down there. And then what we would do is we'd do lateral warm condensation and put as many gutta percha points as we could into the canals. It took a long time. In 2017, I saw this article and it made me feel a little bit better, so I wanted to share it with you. It was in Compendium, and they were talking about, the AAE, the American Association of Endodontists, did a survey of pre-doctoral educators, and the overwhelming opinion was that the current system of pre-doctoral education does not provide the resources to educate students adequately to practice state-of-the-art endodontics. Now, state-of-the-art endodontics is at such a high level today, but 89% of faculty members believe students were not competent to perform molar endodontic procedures. And the concern there is that when these students graduate from dental school, they're licensed to do root canals, whether it be an anterior tooth or a multi-canal molar, and the pre-doctoral faculty did not feel like the students were really sufficiently trained. So 89% of the faculty members believe that students were not competent to perform molar endodontic procedures, and that is probably including a lot of us. You know, if 89% of our instructors didn't think we were ready to go, probably a higher percentage of the students. I don't know. Sometimes ignorance is bliss, so maybe we launched into it thinking we could do anything. But the main concern of the educators was the students weren't well prepared. So if you went through dental school and you found that endodontics was not your favorite procedure when you graduated, or maybe you've now practiced for decades and you still don't think endodontics is a procedure that you would like to practice, then I want to see if I can convince you of some of the advantages now of practicing endodontics. And part of it is just our life expectancy today is just so much greater. We're probably going to live to close to 80 years old if we're lucky. And today I had a patient, she was 103 years old, sharp as a tack. So our life expectancy is growing, and as our life expectancy grows, I had another patient that I was talking with today, and unfortunately, we have this joke when we see each other is that she is outliving her teeth. So today she came in and she's always been battling periodontal disease, and we've been trying to maintain things. But now she's got some teeth where periodontally, I don't think they're going to last much longer. But she is also in her 80s and very good health, and we joke that she is going to outlive her teeth. Here's another patient that I saw recently, and again, the patient's in their 80s. They've been coming to our practice for over 60 years, like clockwork, every 6 months. Everything's been great, but at this appointment, because manual dexterity is down, the vision's down, things just aren't getting cleaned. And so when I ask this patient, how are you doing with your home care? Patient says, I'm doing great. And I look at this and I go, we aren't doing so well. You could see on that lower left bicuspid how there's a lot of root decay that we can see. These teeth have a lot of debris in the anterior triangular spaces, and when I cleaned all that out, we had to do some root canals even on those teeth. And you can see that front left central incisor, the 3-1 or tooth number 24, I've already done a root canal through where I had, because of the angulation of that tooth, we had to go through the facial of the tooth to gain access to the canal properly. But this patient, unfortunately, had more endodontic needs, and if I did not do the endodontics myself, I'd have to refer her out, and which would, getting rides and getting around is very hard for this patient. So for us to be able to do the root canals was advantageous for this patient. And this patient has known our practice for 60 years. She trusts the practice, and as long as we can do good root canal, high quality root canals, then I think it's advantageous for us to keep her in the practice. It just makes her life a lot easier. So we've got the teeth, we've got these diets where even the young patients today, their diets aren't the best. Sports drinks with all the different sugars in them, a lack of effective hygiene. We tell our patients brush and floss, but how many are out there flossing? Not many, and that's clean in between the teeth. Then COVID hit and patients stayed away. And now they're coming back, and that decay that we would catch earlier is now pretty extreme. So we get into this discussion of, well, the decay's into the nerve, and we probably have to do a root canal and then restore this. And the patients are living longer, and as they live longer, the teeth do break down, and we have to do endodontic procedures. But if we can do the endodontics in our own office, it's advantageous. A patient comes in, they've got a large area of decay. We just tell the patient that, hey, we need to do a root canal procedure and then build the tooth back up with a crown, something to restore the chewing portion of that tooth, and we can get it all done, and the patients appreciate this. Now, some of the general dentists are a little hesitant to do the root canals, but I just wanted to stress the majority of endodontic procedures are being done by other general dentists, not the endodontist. One, the endodontists, I think, are busy enough. There probably aren't enough endodontists, and depending on where you live, you may not even have an endodontist that you can refer to that is either close to your office or convenient for your patients. So as a general dentist, and knowing that general dentists do the majority of root canals, if we can offer our patients that service, it saves the patient's time, it's more convenient, they trust you, and then who ultimately will do the restorative work would be you. So I think the ability to do the root canal procedures is a very good service to offer in your practice. Gordon Christensen's survey said about 60% of general dentists do endo, and in a typical GP practice, endodont fees make up about 20% of a general dentist's gross income. So again, if you're not doing any type of endodont procedures, an area that you can grow your practice and grow your overall practice revenue would be adding in endodontic services. So let me ask you, how many times do you see a tooth that could use endodontic services, a root canal procedure? And for many of us, it's sometimes a couple times a day, sometimes at least a couple times a week that we see patients that have this either broken tooth or very deep decay, and in order to restore that tooth, we need to do an endodontic procedure. So what if you didn't do the hard ones, you left the third molars to somebody else, maybe even the second molars to somebody else, but you could do the easy root canals, maybe even the single tooth root canals if you understood the unique anatomy of those. Sometimes a single canal can be difficult, they bifurcate, but we've discussed ways around that during some of these YouTube programs. But what if there were some really easy ones that you could tell radiographically were going to be easy? What if you did those within your practice? So I look at it that should be win-win, right? It should be a win for your patients because they get you to do the root canal. They don't have to go anywhere else. And it's win for you because sometimes in our schedules today we have some openings, and if that patient's in that open time, we can take that open time and actually make it a productive time. And I just put example figures in here. Doing a root canal, maybe it's the fees $1,200. Maybe a post and core $350, a crown $1,600. In general, that service could generate about $3,000 of revenue. Where if you had open time, because maybe you had an emergency visit time and you saw the patient and they needed a root canal and you had to refer that patient out, well, if you could do the root canal service, you could provide that service and maybe even do the restorative work during that same visit. So the way that I'll work it is if I have a patient with a tooth that needs a root canal, I will do the rough prep. I'll scan that tooth. My assistant will start fabricating the in-office fabricated restoration while I do the root canal. And then when we're done with the root canal, we can cement the crown on, which is better for the patient because now I seal up the coronal access so bacteria can't re-enter that now cleaned out root canal system. So we get everything done. It's in one visit. The patient's got one shot, gets numbed up once. We get the crown and the root canal and the cementation done in that one visit. So we end up with a very happy patient. They're out of pain or they will never experience pain, and they got everything done in one visit, which is important to a lot of our patients because it is hard to take time off from work to go to your dental visits. And face it, today, while I'm in California, traffic isn't always the easiest to get around. So if they can get it all done in one visit, 2 hours, instead of having to do an endodontic referral visit, sometimes you refer out to the endodontist does a consultation, then they get the patient back to actually do the root canal. Hopefully it's in one visit, sometimes it's two, so now we're up to 3 visits. And then once that root canal is completed, they have to come back to you to do the crown prep, and sometimes then to have the crown cemented. So that could potentially be 5 visits. Whereas if I get it all done in one visit, the patients are happy about that. So 5 visits, you throw in a half-hour commute time from home to work to your office and back. That's 5 extra hours of time that's taking, much less the clinical time it's taking to get everything done. So it is a win-win proposition when you start to do root canals that you feel comfortable doing in your office and you're able to do the restorative work. Now, endo's gotten a lot more predictable. Before, we did a lot of it by what the endodontists call feelodontics. We would just feel around for the canals, we'd feel for the size of the canals, and today we have magnification and we have CBCTs. We have file systems today where our fingers no longer have to get raw and sore, but we have hand pieces that can actually move the files for us. We just have to regulate how far down and up we take that file. And a lot of these hand pieces now have built-in apex locators, which helps us find the exact length that we need to work that canal and clean it out. And we've covered this in other YouTube programs. We now have irrigants that will really clean out the tissue, the bacteria, chelate and open up the tubules so that when we go there and seal it out with our sealer, that we seal everything up. And before we do the seal, we can use the indicator to be sure we got all the bacteria out, because remember, it's measuring the ATP. So we're going to get all the bacteria out before we seal it up. And so success comes when we sufficiently clean the tooth out, right? We hit all the canals, we get all that tissue out, all that bacteria out, and then we seal it up so that nothing can go from coronal to apical or apical to coronal, right? We get it all cleaned out. So if I get everything cleaned and we don't miss a canal and I don't leave a lot of tissue behind and bacteria behind, and I seal it up, we're going to be good. Endodontics in the past wasn't as predictable. We didn't have good vision. Back when I was learning to do root canals, we didn't have CBCT. Our file systems were hand files, and sometimes they would break or separate. We didn't have apex locators. We had to do it with a PA and a little bit by feel. The irrigants that we had were Clorox, which I've mentioned before in these YouTube programs. We don't know what the concentration or the true activity of that Clorox is, whereas today with our new advanced irrigants, we know how effective they are, and we activate those irrigants so that we get better dissolution of soft tissue and bacterial removal and the smear layer. We have that indicator. We measure the ATP so we can see we have all the tissue and bacteria out. And then today, instead of having to pack the canals with multiple gutta-percha points, we just use a single gutta-percha point with this bioactive sealer. That sealer creates an alkaline environment, the apical area of that root, so that that area will not have post-op discomfort and will heal up. So the way that we do root canals today is so much better. So some of the things that I've mentioned already, but that I've learned is now instead of using hand files, we use rotary and reciprocating file systems that are run off a handpiece. Makes it much easier on my hands. We have graduated from using off the shelf from the grocery store Clorox to advanced and enhanced irrigation solutions. Before, we see on this right hand side is we would use a maximum amount of gutta percha and a little bit of sealer because the sealer would shrink, and like our composite, we didn't want that shrinkage to impact the efficacy of our seal. So today we don't do that. Today we have sealers that don't shrink, or they shrink minimally, but the gutta percha is only there to carry the sealer down to the apex, provide a little bit of a hydraulic force, and give us a way to retreat that root canal treatment if we have to at a later date. So today we use very little gutta percha, just like one master gutta percha point in every canal, but lots of sealer, and that sealer will harden and seal everything up. And the one that I use is bioactive, which is even better. So let me just give you a scenario. Patient comes in, they're in good health. A little bit of a complaint of a little sensitivity over the apical area of tooth number 9, or the 2-1. Now, on questioning the patient about this tooth, they had suffered some trauma during an auto accident about 5 years ago, where the patient's tooth struck the dashboard during the car accident or the auto accident. It's been fine, but now it's starting to feel a little different. So no spontaneous pain. It's not waking the patient up, not even painful when they bite or being a front tooth, drink something hot or cold. But occasionally when they press, especially up at the apical area of that root, it just feels different. So many of us have had these patients. Now, what do we do with this patient? Well, does a patient report pain? Not so much. When they press up here, it feels a little different. So there's no pain. We jump over to 6. Is there radiographic evidence of a periapical radiolucency? Well, on that PA there was. So a good chance we have a necrotic pulp. Does the tooth respond to vitality test? So we would test that pulp with, I just use Endo ice. And if there's no response, then there's a good chance that that pulp is fried, necrotic. At that point, we tell the patient, we don't want this infection to spread, so we need to get in there and do a root canal. We're going to open the tooth up. We're going to clean that infected tissue out. We're going to seal it up so the tooth and bone can heal up around that area. And they're going to retain their tooth, the natural tooth. They're going to have the veneer that's already been placed on that tooth. Nothing about that's going to change, and that infection is going to go away. So when these patients present, it's really your call. What do you feel with that scenario? Do you feel fear? Like, okay, I've maybe found an endodontic lesion. I need to refer out to my endodontist because I don't want to feel nervous about doing this. Or do you feel confident? Like, okay, I think that radiolucency on tooth number 9, the 2-1, indicates a necrotic pulp. I can open that up, clean it out, and take care of the patient. So what is next? It actually depends on your comfort level. And when I'm talking about this, the AAE on their website actually has a case difficulty assessment form, and I just want to kind of show you how it works. Like for myself, I would do a minimally difficult to moderately difficult case in my office. The highly difficult ones, sometimes I'll try them, and like if I've got lots of time and I feel up to it. But a lot of times in a regular busy schedule, I'll probably refer that patient out. So I will manage the minimally difficult and the moderately difficult. So what does that mean? Moderately means, and minimal and moderate means that there's no big health issues I have to worry about. I can numb the patient up. The patient might feel some anxiety, but they understand where that anxiety is coming from, and they are cooperative. They're not going to gag as we're trying to work in the mouth or take a PA. And maybe there's minimal swelling or pain. They haven't blown out their cheek or anything like that yet. So that would be mild to moderate. When you look at some of these things, a first molar would be moderate, second or third molar would be more difficult. If you cannot isolate with the rubber dam, maybe that's a patient you don't want to have to worry about. Let the endodontist take a crack at that patient. Canal morphology, if it's very curvaceous, maybe you don't have the file system that makes you feel comfortable to be able to take care of very curved, severely curved canals. Maybe you've got a really large opening at the apex of the canal because maybe you've got a young patient and the apex hasn't closed up. Some of those things that make it difficult, hey, refer those out. There's nothing wrong with referring those cases out to the endodontist. So pick the cases that you can handle and you can handle without a lot of stress. A history of trauma, if you've got a patient where there's a lot of trauma, like an alveolar fracture, probably want to refer that one out. If you have a history of previous access without complications, that's probably good. If you have a patient has a history where they've gone either surgical, non-surgical endodontic treatments and there were a lot of challenges, maybe you want to refer that patient out. If the periodontal condition is manageable, hey, maybe that's a case you want to keep within your doors. And if it's very bad, maybe we want to create more of a team approach. So in this case, on this central, we got in there, we put the rubber down, you can see the clamps up there, isolated, we cleaned the canal out, we used lots of good irrigation. Now we've got our gutta percha in there to measure it. We used our sealer to seal that. And 6 months later, you can see that that lesion is closing up and things are looking good. The patient really appreciated the fact that we could treat them within our practice. They didn't have to go out. Actually, the day that we did the consultation, so to speak, and took that PA, we were able to do the root canal at the very same visit. So the patient didn't have to come back. They didn't have to go to another office, and we got everything done. So why would you, as a general dentist, want to consider doing endodontics or maybe more endodontic procedures? Because there's definitely a growing need. Our patients are eating more sugar-fied drinks and foods. They're getting decay. COVID didn't help. And our patients are getting older. And as they're getting older, we find drier mouth, less dexterity, poor vision. We're just getting a ton of root decay. I think today there's a lot of knowledge and awareness about root canals and root canal procedures and how they aren't the marathon man procedure of old where they're going to white knuckle it through the procedure. Today with our anesthetics, we can typically numb the patient up sufficiently that we can get into a tooth, clean it out, and it's going to heal up without a lot of discomfort. And improvements in the root canal therapy, again, with the files, with the magnification, the visualization, our irrigants and our sealers, I don't think the fear has to be there anymore on either the patient side or our side. So I think we have finally hit the point where if you're not doing endodontics, I'd recommend that you do more. So what are some of the next steps? Go out and learn. If you're not doing root canals and you don't feel comfortable doing root canals, then take some endodontic courses. Go out there and actively learn. Take a course. Next best would be to read a book, kind of learn the procedures. And I know some of us YouTube it, or sometimes the Instagrams, little 30 seconds, I watch an endodontic procedure and think, oh, I could go do that. But what I would do is I would encourage you to learn how to do endodontic procedures within your office. I think it's win-win. It's going to be good for your practice. It's going to be good for your patients. And right now, this is a book that I'm reading, Dr. Rico Short. I ordered off of Amazon, Endodont Keys and Cases. He does some great cases. It's really fun to watch some of his posts about the healing that he is able to achieve. Very light reading. And if you want to get into endodontics, I'd encourage you, take some courses, do some reading. And I think that's going to change your practice in the second half of 2025. So I hope you liked this information. If you did, hit the like button. If you want to make sure you don't miss out on this information, hit subscribe. Remember, we are creating a community of like-minded individuals trying to provide the very best to our patients that we can in a conscientious way. And if you like that, join our community. Share this information with your friends. Have them join the community. And I will see you during the next program. Thank you very much. Bye-bye.